Good morning, all. Thank you, Carmela. Pleasure to be here. It's always fun to see what kind of chocolate Jeff will have for the speakers. It's a great incentive to come and spend some time here. It's hard for me not to be amused that I'm on the panel for the private payers. I usually, because of my experience, great honor to have run Medicare and Medicaid and chaired MidPAC and the Physician Payment Review Commission before it, am asked to talk about what's going on in Medicare. So this is a fun, different take on some of the same issues that we confront. Carmela and I were speaking before the session started, and what I noted to her is when I look at this particular issue, which is the treatment of complex patients, it's actually one of the areas where the private sector has definitely taken the lead over the public sector. There's always a lot of debate. People are frequently asking me, when do I think the public sector leads? When do I think the private sector can or should lead? My answer is usually it depends on the issue. There are some things that the private sector can do better than the public sector, particularly when flexibility, fleet of foot is important. And there's some things that the public sector can and has done very much better than the private sector, because when it moves en masse, as in Medicare, it moves the whole market typically with it. The reason I say that it's interesting for someone like me to lead off this session is that there's a very easy to understand reason as to why the private sector has taken the lead, although the public sector is working hard to catch up. And that's because particularly in Medicare, Medicare has spent its whole existence trying to get away from the siloed structures that are fundamentally at its base. Even today, when as many as 30% of the seniors and others covered by Medicare are in Medicare Advantage, that means that the dominant number, 70% of the seniors, are still in fee-for-service medicine. And in Medicare, that means you have a silo for Part A, the hospital, and nursing homes, some home care, Part B, the physician component in outpatient, and Part D, the outpatient prescription drug. And while if you have a group of physicians who are sufficiently determined, work hard enough, they can overcome these silos, most of the structures in place make it harder, more challenging than they can be. Now, I want to be clear. It doesn't mean that because the private sector, or Medicare Advantage for that matter, can support coordinated care, that it always does, because in fact it does not always do that, but it has a basic structure in place that allows for care to be coordinated in a way that requires enormous persistence to do in traditional Medicare. Medicare, of course, is attempting to get around those hurdles with its ACO, its shared savings programs, and with other medical home model that they've put in place. They have been having mixed success. It's tough because basically the structure underneath the ACOs and the structure underneath the medical homes is the same regular fee-for-service that has existed, which not only has terrible financial incentives, something that makes economists like me crazy, but makes it hard to encourage the kind of integration that you need, particularly when you're taking care of complex medical patients. Now, the irony, of course, is that we have moved our senior population from a group that is primarily focused on infectious disease, where we were in the early 20th century, to now focusing on chronic disease. That is not only what kills most of us ultimately, but it is also where we spend all of our money. It's true even in most developing parts of the world. If you can survive to 5, you are also likely to die of chronic disease. And yet we see these models that make it very complicated. So the point really is to look at what we are able to see in the private sector and to allow it to help the public sector as well as the large number of patients that are being treated. My two panelists are going to talk specifically about what their companies are doing in terms of making outreach to the complex patients. I want to stand back and say, as I look at this, I see a set of activities that seem to be present in the good programs that we see in the private sector. And again, I want to be clear, I am not so naive as to assume just because you are in a Medicare Advantage plan where a private payer is providing the replacement for traditional Medicare or in a plan for the under 65 population, that necessarily means it's well coordinated. Frequently, we see examples where there's very little coordination, and the financial incentives basically are very much the same as they are in traditional Medicare. That is separate budget silos, and all too often physicians being paid on a fee-for-service basis at a micro level, where the more and more complex the procedures that are provided, the more income they replace. But again, where we see successful activities by the private sector, we are seeing them able to take advantage of their much more sophisticated information systems. I think it doesn't require a lot of explanation to say that the federal government has struggled mightily when it comes to having workable, complex information systems. I was a little surprised by what happened with healthcare.gov last fall. I expected problems. I did not expect the complete, total screw-up that happened. But I expected problems because trying to upgrade IT systems has been very challenging for Medicare 20 years ago when I was there, as well as all of the efforts in between. Being able to make use of sophisticated information systems allows these private payers to be able to target early based on people who have certain diagnoses, who have certain lab test findings, who have emergency room visits associated with particular causes, to be able to receive follow-up treatment that is designed for people who have particular chronic diseases. Being able to work with individuals if they notice that there are missing medications or tests or screenings, having their own ability to look to platforms that can be quite sophisticated in terms of how you manage these patients once you've identified them has been very important. Frequently, there is a focus both on direct member engagement as well as working with the physicians, the clinicians, and the institutions to make sure that the appropriate strategies, empirical-based focus strategies are put in place to treat diabetes or asthma or COPD or heart disease or stroke, are major causes of both spending and death in the United States. It is also easier to make use of the kind of field structure support that is critical in terms of treating these individuals, including now, reminiscent of a Back to the Future mode, the sometimes use of home visits by advanced nurse practitioners or other nurses or other healthcare clinicians who can, if it appears that there are the potential triggers for major medical events that are not being treated, intervene in order to try to prevent further emergency room visits, et cetera. Again, the ability to do so does not necessarily guarantee that these kinds of services are provided. I was thinking about the comment of the last speaker, that if you don't have a delivery structure that supports the proper treatment, you are running upstream in terms of trying to provide this care. I do believe in terms of looking at the Medicare population, it, more than any other population in the United States, is least well served by a siloed payment system, which leads to a siloed delivery system, and can most benefit by an integrated delivery system, which fortunately is beginning to crop up in Medicare. As I've said, we are now up to 30% in Medicare Advantage plans, and some roughly 5 million people in Medicare ACOs. That doesn't guarantee this treatment, but at least it provides a structure where you are not fighting against the structure in order to provide this care. It is identifying the policies that actually work that is really the important next step, and to make sure that they are put in place with rewards, not just financial, rewards for patients using behavioral economics and the clinicians and institutions using all the appropriate reward structure that will facilitate the clinical treatment of what is complex enough, that is providing the appropriate treatment for these complex patients. So this is one of those when people ask me, which they frequently do, where can the private payer lead? This is actually one of those areas. Thank you.